So first of all, let's jump to the introduction of the lecture. When we talk about dental implant, we are talking about osseointegration. But long time ago, we used to say that osseointegrated implant is a successful implant, but not anymore. Osseointegration is not the only parameter that upon it we can judge the success of the implant. Even if you do a precise ceramic duplication of the contour, shape, translucency of natural dentition, still maybe you don't have the exact result that your patient is asking for. What the patient is asking for is a good restoration. Always remember, your patient didn't come to you just to have a nice osseointegrated implant. He won't smile with a nice osseointegrated implant, but your patient will smile with a good restoration. And to have a good restoration, you need to have a good something called emergence profile. What is emergence profile? Emergence profile is the contour of a tooth or restoration while it emerges from the gingiva. And the contour of an implant abutment where it arises from the implant platform. So for emergence profile, it's important to have a good restoration and also to have a good soft tissue management, because emergence profile means a good restoration and a good soft tissue management. When we talk about soft tissue, of course, everyone who places implants knows to manipulate the soft tissue, you need a healing abutment to get a good emergence profile like this one. This is what I can call a good emergence profile, a good soft tissue management. So you need to do some manipulation using whatever healing abutment, using a lot of things. Before I start, I have to tell you something. There is something called biological wets around dental implant and biological wets around tooth and biological constant around dental implant. Biological constant around dental implant, which is 2 millimeters of epithelium and 1 millimeter of connective tissue. So you have all to remember this. I have a biological constant around dental implant, which is 2 millimeter epithelium, 1 millimeter connective tissue. Great. Albert Einstein said, if you can't change the facts, if the facts don't fit the theory, change the facts. You can change everything. You can do new work every day and you can change all the facts that you believe in it. Sometimes you face difficult cases with a horizontal bone defect, gummy smile, smoker patient, then thin gingival bite type. Then here you have an aesthetic challenge for your patient. How can you manage this? And you remember that you have a biological constant around the implant, which is 3 millimeters. What about if I have a thin gingival bite type around my dental implant, which is only 1 millimeter? You know what will happen? If you have a thin gingival bite type, 1 millimeter around your implant, but your implant needs 3 millimeters. So the bone will undergo resorption for 2 millimeters to accommodate for the new biological constant. Which means what? Which means that you will have bone resorption. And it's a great catastrophe. We don't want bone resorption. We are doing everything to have the least amount of bone resorption. So to have a good restoration, you need to have a balance between anatomical and restorative consideration to achieve an optimum aesthetic outcome. 3D implant positioning and soft tissue management at the same time is extremely important. But some patients present a high risk of aesthetic failure, especially soft tissue failure, when they have a defect like this one. They have horizontal defect, they have a thin gingival bite type, and this is the main problem, the soft tissue. The soft tissue is always the issue, because soft tissue is creating the harmonious aesthetic frame of the restoration. When you have a nice picture and you put it in a nice frame, so you will have a nice, better picture at the end. So soft tissue is our frame. Thickness of soft tissue is really important, and the importance of soft tissue thickness around dental implant for maintenance of function, aesthetics, has been widely reported in multiple publications. We always have to measure the thickness of our soft tissue before placing the implant. In our treatment plan, we have to do it. I'm showing here some articles shedding the light of the importance of thickness of soft tissue around the dental implant in maintaining the level of bone vertically and horizontally. A lot of articles talking about this. So management of peri-implant soft tissue is an important and extremely important for preserving the peri-implant bone level. So to keep the bone, you have to keep the soft tissue. When I talk about soft tissue graft, someone will think about, yes, okay, doctor is talking about free gingival graft. Doctor is talking about connective tissue graft. Yeah, we are doing rolled flap. We are doing apically positioned flap. We are doing blah, 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 blah. And mostly everyone is doing a connective tissue graft. You know, connective tissue graft is great. It's nice. But, and you have to put a lot of lines under, but you may have some problems after getting connective tissue. Sometimes, of course, you can get a better pink aesthetic score, but sometimes you will have some necrosis of this graft. And this is a very technically sensitive procedure. Not all of you can do connective tissue graft. And remember something very important. This is a very painful procedure for my patient. And because it requires secondary surgical site to obtain it. You can do it with acellular dermal matrix or whatever. It's all a difficult procedures. Everyone showing cases on Facebook. You know, now we have Faculty of Dentistry University of Facebook because everyone is showing his work on Facebook and everyone like to show a connective tissue graft. But connective tissue graft is very harmful for the patient. It's very, very difficult for doctors to do it. So according to Tom Abbott, he said, it's not about being better, it's about being different. You need to give people a reason. You need to give people a reason to choose your business. Okay, very good, Mr. Tom Abbott. How can we give our patient a reason and how can we do it in a different way? We can do it using the fibrin. I don't know if you know about it or not, because in our blood, we have a fibrin, we have a fibrinogen. But when you have a blood clot, you will have, with this blood clot contained a fibrin network, and inside this fibrin network, you have red blood cells, you have white blood cells, you have mesenchymal stem cells, and you have platelets. Platelets and white blood cells are secreting growth factors. Growth factors are helping mesenchymal stem cells to differentiate into different cells. Mesenchymal stem cells need growth factors to differentiate into fibroblasts, need growth factors to differentiate into osteoblasts. So fibrin, we can use fibrin. Fibrin is the answer. Fibrin is a present, and we can say fibrin also is a future. When we talk about fibrin, we all know about PRF. Everyone knows about PRF, and everyone knows about CGF. We knows about sticky bone, blah, blah, blah. Today, I will talk about CGF, which is similar to PRF, and I'll explain to you what is it exactly. CGF or PRF, one of the fibrin extract product, is one of the materials that can be used to achieve soft tissue augmentation, especially in aesthetic zone. We can use PRF, we can use CGF. It's all the same product, only different commercial names, but it's all the same. The important role here for PRF, for CGF, for whatever, is that it's a membrane, a resorbable membrane. You can use it in surgery. And several studies show a constant release of growth factors like PDGF, TGFB for at least 1 week up to 28 days. And those growth factors will accelerate healing because you have a lot of growth factors for a lot of mesenchymal stem cells. How can we obtain the PRF or CGF? First of all, you collect blood from your patient in specific tubes, then you put it in a specific centrifuge. Here I'm using the Medfuge centrifuge from Silfradent, Italy. And at the end, you have this product. This is the end product, which is the PRF. You see here is the PRF. We have to separate it from red blood cells. We don't need red blood cells, so we simply separate it from red blood cells. Then you see here is a separation. Then we need to compress it because inside this CGF, you have a lot of acellular plasma. We don't want this acellular plasma. We just need a thin membrane. So we only compress this plasma. or PRF, and here is the final product. We have a thin membrane of PRF full of growth factors. Here you have a lot of growth factors. Actually, I have a lot of publications about PRF, about CGF, because this is my main interest, and it's a part of tissue engineering product. I'm working in it with the staff in Barry University and staff in another society, World Academy of Growth Factors and Stem Cells in dentistry in Greece. We are working together on this. So I have a lot of researches. Maybe this was a long time ago. I have a lot, you can see I have almost 15,000 treats, but I believe now it's more than this because I took this screenshot from maybe a year ago. So I believe now it's much more. And a lot of citation, a lot of recommendation. So I have a lot. You can go to researchgate.com and .net, researchgate.net, and just write down my name. You will find all this publication if you are interested. So now I personally invented and created 3 ways to manage soft tissue around dental implant in aesthetic zone with a very easy way, because this is what I'm looking for. When I do an implant course, the address of my implant course is Art of Simplicity. I always teach my student to do this, to do everything with a simple way. Keep it simple and silly. So I will show you 3 techniques to get a very nice soft tissue around your dental implant with a very easy way. Any GP can do it. And let's start with reverse mid-crustal incision, which is my own techniques that I developed, and I developed in 2012, but I published in 2016, and I called it a vertical mid-crustal incision flap design in 2nd stage dental implant surgery in aesthetic zone. Let me explain to you on this video the technique. All you have to do to create papilla is to make a buccopalatal incision. Only one buccopalatal incision, which is very easy. Then use your periosteal elevator to make a kind of separation, or just push the tissues mesially and distally. Take out the cover screw and put a narrow healing abutment. Leave the narrow healing abutment for 1 week, then take it out and put a wider healing abutment. See, we have a wider healing abutment. What is happening here? What is happening with this technique? First of all, you are cutting a buccopalatal incision. Okay, what after the buccopalatal incision? Let me show you on a case. What you are doing, you are cutting a buccopalatal incision. When you cut a buccopalatal incision, so you are not cutting any blood supply. This is very important. You are not cutting blood supply. Just this is one incision, and it's very easy. Anyone can do this incision. It's very easy. So just one buccopalatal incision. Push with your periosteal elevator, mesially and distal, take out the cover screw and put a narrow healing abutment. Now, after putting the narrow healing abutment, what will happen? The narrow healing abutment will push the soft tissue 3-dimensional, buccally, mesially, distally, and palatal. What's next? 1 week later, and look at this picture. This is a fantastic picture. What I have here. Look at the tissue expansion. It's obvious now. Now you can see that we have a very nice tissue expansion, 3-dimensional, mesially, distally, buccally, and palatally. I have 3-dimensional tissue expansion. Then I need a bigger healing abutment to push the tissues more mesially and distally, and of course also buccally. Now you are creating a thick band of keratinoids because around your future restoration, mesially, distally, buccally, and palatally, which is perfect, very good. At the end, you can fill the dark triangle with soft tissue, and you have something similar to papilla. Actually, I have a lot of cases like this. You can see here the buccopalatal incision, then healing abutment, and you can notice the blanching in the tissues. You see the blanching in the tissues. So the healing abutment is pushing the tissues all 3-dimensional. Then I have to put a wider healing abutment. You see here the tissues. Then I put a wider healing abutment, pushing the tissues more and more mesially and distally. Then I can have soft tissue in the interproximal area similar to papilla. And when you put you see here, I have a very nice soft tissue and a very nice emergence profile. After putting my final restoration, I will have a papilla around the dental implant. So you can see, we have a lot of techniques creating papilla, but it's very difficult and it requires a microsurgery tools. But now with only one incision and the use of 2 healing abutments, you can create your own papilla. Even you are a GP and you are not a surgeon, you can do it in a very nice way. Second technique, which is very important in my work now, and I'm using it a lot with a lot of modification, is a pouch technique. Simply, if you have a narrow buccopalatal bone, if you have a narrow buccopalatal bone, you have a horizontal defect. If you have a horizontal defect in your soft tissue and you need to gain more soft tissue, someone will tell me, doctor, I'm going to do connective tissue graft. Yes, you can do it with connective tissue graft, but you can also do it with different ways, but you can do it in an easy way. Let me show you, because sometimes you have this problem. You have, as you can see, you have a horizontal defect here in the soft tissue, and you need to gain soft tissue thickness. And you need also to increase the soft tissue thickness around the dental implant in order to avoid bone resorption. So also I developed my own technique here, and I published also in 2016. I called it a minimal invasive pouch technique. And I will explain to you here how this pouch technique is working. So let me show you in this video, minimal invasive pouch technique. All you have to do is just a buccopalatal incision. Look at here. All you have to do is a mesodistal incision. Just one incision. You see here, we have just one incision. And then with my full thickness incision, then with my periosteal elevator, I'm creating the pouch. I'm opening and creating the pouch. And inside this pouch, I'm inserting PRF or CGF or whatever the fibrin you are using. Taking just one suture. I have hundreds of cases like this one present. Okay, what will happen here? What will happen? Now you have a gap, you have a space because you created a pouch. Okay, and what will happen after this? The fibrin will act as, you inserted the PRF inside. The fibrin will act as a filler inside, okay? So you have a filler to preserve this space. And platelets, white blood cells will secrete a lot of growth factors. These growth factors will help circulating mesenchymal cells to differentiate into fibroblasts. And with those fibroblasts, you are creating in situ connective tissue graft. So you are creating new connective tissue graft. You are not getting connective tissue graft from somewhere else and putting it here in this place. No, you are creating a connective tissue graft. Let me show you. This is an old case, and you see we placed our implant palatal as usual. We placed in an immediate placement case. We placed implant palatal as usual, and we placed here bone graft buccally, normal. But the patient came with a defect. She wasn't happy. She told me, doctor, I have this defect. I'm not happy. So I told her, okay, I'm going to treat you with this pouch technique. Let me show you what I've done to this patient. You see, here is the mesodistal incision, and here is a PRF inside. I put PRF inside, PRF, and let me show you this picture, because I can say this picture has the Oscar of the best picture. And I will magnify to you now to show you something very important. You know, what is the white color? The white color is the PRF, the fibrin. And what is the red color is the new tissues. So without magnification, you can see you have now the PRF is integrating with the new tissues. Or let us say it with another way. The new tissues is integrating inside the PRF. The PRF is becoming a part of the new tissues, which is fantastic. And now you can see we have a good thickness soft tissue in comparison to the preoperative. You see, 1 year later, we still have our sickness. And another 1 year after, I took out the implant to clean, I took out the crown to clean, and I still, as you can see, I still have my soft tissue contour. You will have it for her lifetime, for your patient lifetime. You are here creating in situ connective tissue graft from the patient blood. You don't need to take out a connective tissue from the palate and put it here. You don't need, and you don't have to harm your patient. I will show you here by video how to do it and how to do this technique. Results. Of course, I will show you a picture now of, you see, also I put a piece of PRF between the healing abutment and my incision. And let me show you pre and post-operative. Here is the pre-operative, and you see the final, much more better than previously. You see the soft tissue contour, it's totally different. I have now a very nice soft tissue contour. So again, with just one incision, anyone can do this incision. Anyone can do it. Just one incision, putting the PRF inside, you can get a fantastic result. You're getting a fantastic results because you're respecting your tissues. When you respect your tissues and you're doing it with a minimal invasive way, you will get a very nice results at the end. When you respect the tissues will respect you back. The third technique, or I can say it's not a third technique, it's just a modification, and this is what I prefer now. It's a modification on the pouch technique, and I called it a Vista technique. It's the same, but my incision in a different way. I will show you now in this video. Now I make incision, vertical incision, then I'm creating a tunnel. You see, I'm doing a vertical incision, then creating a tunnel and inserting the PRF. Here I'm doing the same. PRF will act as filler, will initiate healing, and will get faster bone formation. And one more thing, when you are doing it in the upper jaw, in the maxilla, the PRF with its weight, it will push the tissues down. So if you have a kind of recession, the gingiva will go down, covering this recessed part. That's why I always prefer this. This is a modification, and I prefer to do this. You can see just by one simple incision. I have only one incision. I have hundreds of cases and videos explaining this, but of course, it's only 45 minutes or 1 hour for a lecture. So I have to show just 1 or 2 cases for everything. So one incision, creating the tunnel, then inserting the PRF or CGF inside, and here is the day of the surgery, and you can see 3 months later, very nice result. At the end, I have a good result for my patient, and it was like this, and now it's like this. Oh my God, very good. Pre-operative, you can see here the pre-operative and the final, pre-operative and the final. Big difference. 1 year follow-up. So I have no more defect. I have a thick keratinized mucosa around my final restoration. I will show you another case. The patient came complaining from, she placed implant somewhere else, but she told me, doctor, I don't like this appearance. I don't like this depression. How can you solve the problem to me? Because I know someone told me you are doing an easy technique, minimal invasive technique to solve this problem. I told her, okay, let's do it. So just 1 incision, a very small, less than 5-6 millimeter incision, very small incision, and inserting, you can see the incision here, inserting the CGF or PRF inside. And you can notice while pushing or while creating my tunnel, you see now the soft tissue is in a good position. The soft tissue is in a good situation. And the PRF will push it down to maintain it in this position. Immediately after inserting the PRF and then taking the suture, and you see now the soft tissue is going down more. And with PRF, it will go more and more down, and we have here a much more better result than previously. She was very happy, the patient, pre-operative and after. Of course, if you do this immediately after implant placement, this will be much, much more better. So we were talking about reverse mid-crestal incision, pouch technique, and my modified also Vista technique. The last technique I'm going to show to you now is a custom-made healing abutment. Usually, we used to use a normal healing abutment for reshaping of soft tissue, but let me explain to you something very important. In any company, any implant company, you have only 3, 4, 5, 10 shapes for healing abutment, but you have millions of people with different shape of their soft tissue. Okay, great. So can I use only 10 shapes of healing abutment for all patients? You can do this in posterior, but in anterior, you can't do this. You have to do a kind of modification. So we used to use a temporary crown instead of healing abutment. Temporary crown just to reshape the soft tissue. And the best thing to do with the temporary crown is to reshape the temporary crown with flowable composite. Let me show you a case and explain to you. Here is my buccopalatal incision, which is a reverse mid-crestal incision, narrow healing abutment. Then instead of putting the wide healing abutment, I'm just putting a temporary abutment. Here is a ready-made crown. And the most important part here is to reshape the cervical area with flowable composite. You can see here, now I have a very nice shape for my crown in the cervical area with flowable composite. This is very good. I put it in my patient mouth. Soft tissue start to reshape around this temporary crown according to my flowable composite and the temporary crown shape. And at the end, you can start to have a soft, nice soft tissue around your final restoration. But there is something important. When I put my flowable composite, I'm putting my flowable composite according to what I'm thinking it's good. According to what I see, it's nice. Yes. But this is not scientific. There is nothing written in the book. Dr. Ahmed thinks this is nice. Dr. Zhao thinks this is good. No. You need something, evidence, you need measurements. You need to know how to put the flowable composite in a nice way. So a friend of mine, Dr. Baron Grater in the States, he invented or he created something very nice, a software called Emergence, or a plug-in on 3D software called Blender, and the plug-in called Emergence Profile Generator. You can just generate this block on the software. You can do this block. You enter some, you input some items, size of the teeth, which teeth you are going to, you need to manufacture a healing abutment for which teeth, size, shape of the teeth, blah, blah, blah. And you can choose between different shapes for your healing abutment. You have a deep bowel, you have a bowel, you have an hourglass, and there is a lot of shapes. Then you print it with your 3D printer. You can see here, this one is printed with a 3D printer, lower right 6, lower right 5, lower right 4, everything. And you put your abutment or temporary abutment inside and fill it with flowable composite around. I put my abutment. Let me show you this video. I'm creating a custom-made healing abutment. This is a 3D printed block. I put separating medium, then etching and bond on my abutment. I put my abutment in position. Then flowable composite around. Around the flowable composite, curing the composite. And even I can put more composite and make a temporary crown over the remaining part of the abutment, or I can cut the abutment to use it just a healing abutment. And the best now to do is to use the tie base abutment. It's very nice to use it. So at the end, you see now I have what I have. I have a custom made healing abutment. This one, I have a custom made healing abutment. And we made a lot of modification on this. Let me show you, I will show you something. It's not on the presentation, but I'll show you on the camera. We made one flexible now. Flexible, so I'm printing it with flexible resin. Flexible one, so you can easily take it out, the abutment from inside. And I've done a big one. I created the bigger one. This bigger one, it has two shapes of the healing. If you need an hourglass, if you need a reverse bowel, I've created this, and also flexible. This is a modification I've just done a few weeks ago. Or you can have it like this, a solid one, but I prefer the flexible ones than having the solid one. So let me show you a case. This guy came to me with a broken central, and he was in a fight, I don't know, or whatever. Came to me with a broken central and extracted out other central. I think he got a punch or something. And I told him, okay, we have to place implants for you. We have to check. So after opening the flap, you can see we have a mess here. We have a missing buccal bone here, and you see a very thin buccal plate of bone. Usually in a case like this, it's preferable to make socket preservations than place your implant later on. But I prefer, since in the cone beam, I've seen that I have a treasure of palatal bone. I have a lot of palatal bone. So I created a new socket in the palatal area. Usually in upper anterior, you have to place your implants palatal. So I'm doing the right thing. I'm placing my implants in the palatal area. And you can see here, I have two paralleling pins. I have two new sockets. I continue drilling, then I place my implants, two implants, and of course I have to put bone graft here. I can't leave the socket like this because I have also exposed threads for the implants. And here I'm using also an extract of fibrin called sticky bone. It's the same. You are creating a mass of PRF, but inside you have bone graft. Putting all the bone graft all over the implant and filling all the gap. Later on, the patient came to me. Obviously, I have a good healing, and here you can see the buccopalatal. You can see here the buccopalatal incision, which is a reverse mid-crestal incision. Putting the healing abutment. Yes, you can see now the healing abutment is three-dimensional, expanding the soft tissue, pressing on the soft tissue. After 1 week, I took out the healing abutment. This is not a good emergence profile. I need a wider abutment, or I need a custom-made healing abutment. I created the crown over it, but I don't have the picture. So now, yes, I started to have a papilla. I started to have a good emergence profile for my patient, taking an impression for my patient. And let me show you the post-operative or the final X-ray, which is very important in a case like this. Here is the pre-operative situation, and here is the final situation. You can see this is my new bone. And you can notice that my new bone is much more better than the patient bone itself. I have a very good bone for my patient, and the patient was totally satisfied because I got a fantastic results at the end. Let me show you another case. The patient came with this terrible restoration. He wasn't happy, and he told me, "Doctor, look, I don't want bridge anymore because bridge is destructing my teeth. I need implants, please." I told him, "Okay, we have to clean everything." I placed implants, and you can see here is a custom-made healing abutment in position. And now, yes, I have soft tissue. Now I have soft tissue modification. I started to have a papilla because of the custom-made healing abutment. It's much more better than using a normal healing abutment. And here is the final restoration. You can see now we started to have a better tissue contour. And when you wait for 2-3 months later, you will have better tissues. More 1 year later, better tissues. You have stable tissues for your case. Of course, this patient needs a veneer because we told him you need a veneer. You have to go to another, because we only do implants, you have to go to someone else to do the veneer for you. I'll show you a final case before I jump to my conclusion. Another implant placed by my colleague, Dr. Abdullah, working with me in the center, and buccopalatal incision, narrow healing abutment. You can see then a custom-made healing abutment, and we have a nice emergence profile and a nice final restoration. You see, this is immediately after inserting the restoration, and 3 months later, it's much more better. Why? You are respecting the tissues are respecting you back. Another case, it's all the same. You see, we are going to extract this tooth. We took out the tooth, we placed our implant, then the buccopalatal incision. Here is the implant, we placed our implant. The patient came back later on, custom-made healing abutment for the patient. You see, I'm doing the custom-made healing abutment. Now I have a good emergence profile for my restoration, and final restoration. Soft tissue contour is nice. This patient, I placed this crown a week ago. I have to do a kind of gingivectomy to make just a contour here. I will do it by laser to make a nice contour here. And finally, jumping to the conclusion. Implant therapy in the static zone requires careful planning and sequencing of treatment. Hard and soft tissue deficiencies may require multiple procedures and have a varying degrees of predictability depending on the size and nature of the defect. Preservation of the natural soft tissue architecture may optimize results and decrease surgery-related morbidity. The use of growth factors concentrates in the form of PRF, CGF, lead to better aesthetic results on soft tissue level with the advantage of less invasive technique and better wound healing, which really enhance the clinical end results and increase patient satisfaction. At the end, you know who is this girl? Of course, all of us know this girl. Long time ago, when we were kids, we used to listen to the story and see the movies. Our kids now see the videos of Cinderella. What is the moral of Cinderella story? Cinderella never asked for a prince. You all know that she never asked for a prince. All what she wanted is a night off and a dress. But because she has done this in a very nice way and in a perfect way, she got a good results at the end. So this is what I'm telling you. Do your work in a nice way, in a gentle way. Be gentle, please, with the tissues, like what I'm showing to you. You don't have to take soft tissue from here, put it here. If I take your nose, if I take out your nose and put it back with a nice suture, you can call me a non-traumatic surgeon? Of course, no. You have to do it with the simplest way. You don't have to open a flap and take a connective tissue graft and leave the patient suffering from pain to put it here, while you can just take some blood centrifuge and do it with a nice way. So at the end, you can see we can do everything in a nice way. And when you do it in a nice way, the tissue's response will be very nice to you. Thank you very much, and I really appreciate being here with you. We have 116 participants, which is fantastic, very good. And I'm really very happy to be here with you. And I hope you enjoyed the lecture with me. I have a channel on YouTube, which is called, it's not my full name, it's Ahmed Ayoub, a channel on YouTube. You can follow all my surgeries and those lectures and so on. And thank you very much. This is my Facebook. This is my email if you need to ask for anything. Thank you very much for being with me in the lecture. And I believe if you have any questions, I can be here with you.